Okay, so here we're going to talk about the Mycobacterium group of bacteria. And so the famous Mycobacterium, of course, is tuberculosis, but we will talk about a few others as well. And the Mycobacterium have a very unique cell wall structure. They're going to have a very high lipid content, and they're going to also have a specific type of coating on them that makes them very waxy. It's mycolic acid. And mycolic acid is going to be a target of a drug for treatment of Mycobacterium tuberculosis. And then you're also going to have a rabinogalactin, which is going to be in the outer wall of the Mycobacterium as well. And then that one is going to be important for the bacterium connecting the peptidoglycan to the mycolic acid cell wall. There is also a cord factor, and this rabinogalactin is going to be a target also of our anti-mycobacterium treatments. We have cord factor, which is going to be toxic to mammalian cells, and it also prevents the polymorphs or neutrophil migration. So it's really going to be important in forming those granulomas. And then we also have purified protein derivative, or Ppd, which is known for its tuberculin skin tests. And so your Mycobacterium in general, all of them will have these unique features. And tuberculosis, of course, has additional virulence factors as well. So Mycobacterium tuberculosis is able to survive inside of our body partly because it can prevent your phagosome lysosome fusion. And so when it gets eaten by a macrophage, it is not going to, the macrophage will not be able to kill it how it normally would kill other bacterium through the radical oxygen, the oxidative burst, and things like that, because Mycobacterium prevents that. Mycobacterium will grow inside of the endosome compartment. It does not get into the cytosol, and it replicates inside that endosomal compartment. And many of its proteins will be released, and those are what are going to cause the features of tuberculosis, such as this Ghosn complex. And so the Ghosn complex, if I blow this up, is basically what is found in the lungs. And so your Ghosn complex is a non-pathognomonic radiograph finding. And this is typically by a chest x-ray. And this is a significant finding for diagnosis of tuberculosis. It's going to be in the subpleural part of the lungs, and it's also going to be predominantly in the upper part of the lower lobe and in the lower part of the upper lobe. And what makes up this Ghosn complex is our multinucleated giant cell, which has these foci where your Mycobacterium tuberculosis is actively dividing inside of that. And a multinucleated giant cell is basically going to be your macrophages fusing together. And so the nuclei, which are these blobs, I'm sorry, they're not the vesicles, those are the actual nuclei. The nuclei are just from individual macrophages. So it's not like it's dividing or anything, they're just fusing. You also have epithelial macrophages present. You're going to be surrounded by a lymphocyte population, and in the center is always going to be some sort of necrosis, which is basically your dying epithelial cells and macrophages. Now this guy is going to have a slight curve in structure. It's referred to as a slender rod. It is going to be acid-fast, so you do acid-fast staining instead of gram staining on Mycobacteriums. This one also has a slow growth. So the doubling time is in 20 hours, and this is one of the major factors with respect to antibiotic resistance. So in order to clear this infection, patients have to be on antibiotics for a very long period of time, and compliance with the antibiotic treatments is often one of the factors with respect to antibiotic-resistant bacterium. Now, the reservoir is going to be humans. Transmission is person to person. Your lung infection can spread and you can get dissemination or miliary TB. Now, clinical symptoms of tuberculosis are basically going to be you have a cough, which is going to be associated with many respiratory infections, but you also have chest pain, night sweats, a loss of appetite, a loss of weight, and the primary causes are going to be, of course, our tuberculosis. There are some others. There's Mycobacterium bovis and Mycobacterium canasi, which can cause similar symptoms. And then Mycobacterium avium is going to cause primarily this pulmonary tuberculosis in immune-compromised, especially HIV-infected patients. So tuberculosis always seems to be climbing instead of declining. So about a third of the world's population are thought to be infected, which means that transmission is about 1 person per second. Most people will not develop active tuberculosis. So this, even though there's a lot of people infected, about 5 to 10% of them will present with some sort of disease. However, these that have active tuberculosis are the spreaders. And so they're the ones that are continuing to affect new people. And so you get about 8 to 10 million new cases every year. This has a pretty high burden on worldwide mortality and about a 6% burden with respect to TB. Risk factors are going to be basically close contact to a source or case. And so healthy individuals that get exposed to tuberculosis will get infected with tuberculosis. And tuberculosis is a chronic infection. You never clear it. Even if you don't have active TB, basically your immune system is keeping the bacteria suppressed, so you don't have symptoms. But if you become immune compromised in any way, you can develop active TB. Increased risks are going to be, of course, HIV infection that's associated with both Mycobacterium tuberculosis and avium. Drug abuse, age can be a risk factor, any type of immunosuppressive therapy, if you're on transplant therapy, autoimmune therapy, etc., diabetes, and malnutrition. Now, outcomes of TB are basically you are going to get some sort of exposure event, and then from that exposure event, about 25% will become infected. And keep that in mind that most people who get exposed do not become infected, so it's not 100% transmissible. And then of these 25 to 30%, only 5 to 15% will get active primary TB. Now, if you're HIV positive, this of course jumps to 40% active primary TB. So it's a very big difference from an immune competent to immune compromised individuals. Most immune competents will not have active TB. For HIV positive, it's unclear how many of them are actually asymptomatic. Most asymptomatics will become lifelong containers, so they're not going to develop active TB. Some of those that became asymptomatic after primary exposure will reactivate, and these reactivated cases are usually the cause of new cases every year. All right, so tuberculosis is important to monitor because, again, for people who are having active TB, those are the spreaders. And so there's a lot of resources put in identifying those active TB cases. There's the tuberculin skin test, which is a very easy test. It's also called the Mantoux test. And so that's where you have your Ppd injected into your skin. There's also an interferon gamma release assay, and this is useful for Bcg vaccinated individuals because Bcg is the vaccine for tuberculosis that's used in many countries around the world, not in the United States. And Bcg vaccinated will always be TB skin test positive. So the interferon gamma release assay is very important because it will help to identify if a vaccinated person is actively responding to the vaccine or to the tuberculosis, and so it's looking for activated T cells. Now, tuberculosis can also be stained. So you can do a stain, it's called an acid-fast bacilli stain. However, it does have poor sensitivity. It takes 24 hours, so it's relatively fast. Nucleic acid amplification tests and PCR are going to have better sensitivity, and again, the results can be done in a few days. Culture is a gold standard, but it takes many weeks to culture this bacterium because of its slow growth. So control measures are, of course, screening people. So you want to identify people who need to have treatment, and those types of people would be those that are Ppd positive or that have active tuberculosis. The Mantoux skin test is, again, that injection of your Ppd antigen from the bacterium, and then you see this response 48 to 72 hours later. And it is a delayed type hypersensitivity reaction in which your helper T cells are interacting with macrophages at the site of the injection. Now, typically a positive skin test won't develop until 2 to 10 weeks after you've been exposed to tuberculosis. So it can't pick up people who have just been recently exposed and could potentially be activated. If a person does become positive, they usually remain positive for their life because tuberculosis is an infection. It causes a memory response in your T cells, and those T cells are going to be lifelong. Now, a positive Ppd test will tell you that you had a previous or present infection, but it does not identify active TB. So when you take a measurement at the induration of the raised inflamed area that develops, the induration, which is at the injection site, you're looking for thickening or hardening, and you have different sizes based on the individual you're testing. So if the individual is a low risk, meaning that they don't have any risk factors, they're not immune compromised, they haven't been exposed to somebody they know that has TB, then you would be looking for a relatively large size reaction, because some people do have allergic reactions to whatever is being injected, so you want to make sure that you're not measuring an allergy to the actual injection. You want to make sure that you're actually measuring the response to the Ppd. If you're a moderate risk, meaning that you come from a country that's maybe has higher incidence of TB, or you're in a long-term care facility, then you would be looking for a smaller induration. And then high risk, which means you had close contact with an actual active case, or you're some immune compromised, HIV positive, you use drugs, etc., then you'll be looking for a smaller induration or positive. And when somebody's positive, that's not the end, of course, of their testing, as many people know. You'd then go on to get an X-ray or take one of those other tests that we just talked about. Now, treatment approach. So, of course, TB or active TB is going to be a slow-growing bacterium, and this is going to be correlated with a high rate of spontaneous drug resistance, and this requires prolonged multi-drug treatment regimens. And so we have our first line of antimicrobials listed here. And you can see that they're going to target the bacterium. So we have one that is going to target the synthesis of glycolic acids, and so this will be bactericidal. We have rifampin, which is going to inhibit DNA-dependent RNA polymerase. This is also bactericidal. However, resistance to this develops rapidly. Pyrazinamide is an unknown, its target is unknown, and it also works best with an acidic pH. Ethambutol is going to again inhibit that arabin glycan, and that's the one that is going to link the peptidoglycan to the mycolic acid in the cell wall. And so this is going to be bacteriostatic, and resistance is going to develop rapidly for this one as well. So when you look at a time course for treatments, and again, this is after diagnosis, not after exposure. So after diagnosis, you're going to be put on those first round, and you're going to have all four potentially be given. So it just depends on what type of TB you have. If you have a resistant strain, you're going to put on 3 drugs, and then otherwise it's going to be the 4 drugs. In the Bay Area, we're going to use more than 4 drugs in the treatment of this. You can have exposed or recently Ppd positive, in which you have a latent tuberculosis. You will have a different regimen of drugs that we'll use. But again, it's always going to be very long-term and sometimes even go out for years. So the emergence of multi-drug resistant TB. The multi-drug resistant TB is going to be to at least 2 of the drugs that are typically used. And these are very powerful first-line anti-TB drugs that the multi-drug resistant TB is resistant to. The X-drug resistant TB is extensively drug-resistant TB, which is the multi-drug resistant TB plus resistant to any of the fluoroquinones, or at least 1 or 3 injectable second-line drugs, which are listed here, kanamycin, for example. And then you have your extremely drug-resistant TB, which is given in XX, and this is resistant to all first-line and second-line drugs. And so in December of 2009, the first U.S. case of that extremely drug-resistant TB was identified. Now there is a vaccine to TB. It's called the Bcg Vaccine, Bacillus Calmette-Guerin. And so this is a vaccine that is alive attenuated. So the vaccine is still, or the strain of the Mycobacterium is from bovis, and it is still live. So it's going to have the ability to prevent clinical tuberculosis primarily in children. It does not prevent infection, and so it's only used where there's high incidence of tuberculosis, such as India, and they use BCG vaccine. It is not going to be routinely used in the United States because our incidence is low, and it interferes with the Ppd skin test, so everybody would have to have an X-ray or another skin test. And also, it's a chronic infection. The BCG vaccine will infect your lungs, so bovis will get into your lungs, and it will stay there for the rest of your life. It will not cause TB, but it still is a chronic infection. Now, so other mycobacteriums that are important is avium. Mycobacterium avium intracellular complex, MAI or MAC. This is going to be associated with AIDS patients primarily. So if you have a person who has AIDS, 50% of all AIDS patients develop TB or Mycobacterium avium intracellular. If you really look at those patients, 40% of them are Mycobacterium avium caused. Now, the reservoir is going to be environmental as well as in birds and animals, so basically it's going to be everywhere, ubiquitous. Transmission is through environment. Avium is not transmitted person to person. The treatment is going to be similar to tuberculosis, a prolonged multi-drug therapy. This can be up to 6 different drugs. And you're going to use many of azithromycin, clarithromycin, etc. There is no vaccine, so BCG does not work against Mycobacterium avium. You can also do chemoprophylactic treatment of HIV patients to prevent a Mycobacterium avium infection. The next mycobacterium that is famous is Leprae. This is also referred to as Hansen's disease because it was discovered by Dr. Gerard Hansen in 1873. It's a very ancient and feared disease. It's also endemic in many areas of the world, especially in tropical areas. It was introduced from Asia to Europe by Alexander the Great. And so your drugs, In 1995, the World Health Organization decided to take a stab at getting rid of leprosy, and they did this by making drugs free to those who had leprosy. And so since then, about 14 million people have been cured from leprosy, and there has also been a 90% drop in the incidence of leprosy. So that was a huge effort, and it was a very successful effort. Now, leprosy is going to have two basic reservoirs, humans, so human-to-human transmission, as well as our friendly armadillo. So the transmission is through nasal secretions, someone has a cut or an abrasion, or it's through some prolonged contact. So if you are in contact with someone with leprosy, you have a 5% chance of getting infected. So therefore, it's not very contagious. There is a Leproman skin test similar to the Ppd skin test. It usually is very long, insidious, so we have 2 to 10 years for the symptoms to actually develop. So you might not even know when you got exposed to the Leprae bacterium. Pathogenesis is similar to Mycobacterium. It's an intracellular pathogen. In this case, it grows best at 30 degrees C, so it's not going to grow good in your lungs like tuberculosis or even inside of your body. It likes to replicate in superficial tissues such as your skin, your upper airways, where it's a lower temperature because of exposure to air. It's going to replicate in skin histocytes, endothelial cells, and those nerve Schwann cells. One of the first signs is a hypopigmented skin lesions that develop on patients. Now, Mycobacterium leprosy is going to lead eventually to superficial nerve thickening and a general anesthesia feeling, which means you have a loss of sensation. And so this is bacillary form of leprosy, PB. And when you start getting into more dissemination type of leprosy, then that goes towards a multibacillary form of leprosy. And you start to lose the ability to pull away your hand with hot objects, sharp objects. You have a very thickening of the nerves. It also disseminates to other organs. So you start to see blindness in your eyes, your loss of fingers, toes, etc. So you get your extremities at different sites of the body are going to be impacted. Now, treatment, as I said before, is going to be multi-drug treatment, 6 months to 2 years. You wait until you no longer have the bacterium in the skin. There's a list here: dapsone, ribampin, and these are all going to have an effect on the bacterium. So you have rifampin again that binds to the RNA polymerase, and clofazimine also binds to the DNA, and it prevents the RNA polymerase from binding. So both of them have similar effects, but they have different targets. You're going to have different regimens, whether you have the paucibacillary or multibacillary form of the disease.